Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Alectinib in resected ALK-positive non-small cell lung cancer. Background: platinum-based chemotherapy is the recommended adjuvant treatment for patients with resectable, ALK-positive non-small cell lung cancer, NSCLC. Data on the efficacy and safety of adjuvant alectinib as compared with chemotherapy in patients with resected ALK-positive NSCLC are lacking. Methods: we conducted a global, Phase 3, open-label, randomized trial in which patients with completely resected, ALK-positive NSCLC of stage IB, tumors greater than or equal to 4 cm2 or FIA, as classified according to the 7th edition of the Cancer Staging Manual of the American Joint Committee on Cancer and Union for International Cancer Control, were randomly assigned in a 1-to-1 ratio to receive oral alectinib, 600 mg twice daily, for 24 months or intravenous platinum-based chemotherapy in 4 21-day cycles. The primary endpoint was disease-free survival, tested hierarchically among patients with stage 2 or FIA disease and then in the intention-to-treat population. Other endpoints included central nervous system, CNS, disease-free survival, overall survival, and safety. Results: in total, 257 patients were randomly assigned to receive alectinib, 130 patients, or chemotherapy, 127 patients. The percentage of patients alive and disease-free at 2 years was 93.8% in the alectinib group and 63.0% in the chemotherapy group among patients with stage 2 or FIA disease. Hazard ratio for disease recurrence or death, 0.24, 95% confidence interval, C, 0.13 to 0.45, P less than 0.001, and 93.6% and 63.7%, respectively. In the intention-to-treat population, hazard ratio, 0.24, 95% C, 0.13 to 0.43, P less than 0.001. Alectinib was associated with a clinically meaningful benefit with respect to CNS disease-free survival as compared with chemotherapy. Hazard ratio for CNS disease recurrence or death, 0.22, 95% C, 0.08 to 0.58. Data for overall survival were immature. No unexpected safety findings were observed. Conclusions: among patients with resected ALK-positive NSCLC of stage IB, 2, or FIA, adjuvant alectinib significantly improved disease-free survival as compared with platinum-based chemotherapy. Trial of early minimally invasive removal of intracerebral hemorrhage. Background: trials of surgical evacuation of supratentorial intracerebral hemorrhages have generally shown no functional benefit. Whether early minimally invasive surgical removal would result in better outcomes than medical management is not known. Methods: in this multicenter, randomized trial involving patients with an acute intracerebral hemorrhage, we assess surgical removal of the hematoma as compared with medical management. Patients who had a lobar or anterior basal ganglia hemorrhage with a hematoma volume of 30 to 80 milliliters were assigned, in a 1-to-1 ratio, within 24 hours after the time that they were last known to be well, to minimally invasive surgical removal of the hematoma plus guideline-based medical management, surgery group, or to guideline-based medical management alone, control group. The primary efficacy endpoint was the mean score on the utility-weighted modified Rankin scale, range, 0 to 1, with higher scores indicating better outcomes, according to patients' assessment, at 180 days, with a pre-specified threshold for posterior probability of superiority of 0.975 or higher. The trial included rules for adaptation of enrollment criteria on the basis of hemorrhage location. A primary safety endpoint was death within 30 days after enrollment. Results: a total of 300 patients were enrolled, of whom 30.7% had anterior basal ganglia hemorrhages and 69.3% had lobar hemorrhages. After 175 patients had been enrolled, an adaptation rule was triggered, and only persons with lobar hemorrhages were enrolled. The mean score on the utility-weighted modified Rankin scale at 180 days was 0.458 in the surgery group and 0.374 in the control group. Difference: 0.084. 95% Bayesian credible interval: 0.005 to 0.163. Posterior probability of superiority of surgery: 0.981. The mean between group difference was 0.127. 95% Bayesian credible interval: 0.035 to 0.219. Among patients with lobar hemorrhages and -0.013. 95% Bayesian credible interval: -0.147 to 0.116. Among those with anterior basal ganglia hemorrhages. The percentage of patients who had died by 30 days was 9.3% in the surgery group, and 18.0% in the control group. 5 patients, 3.3%, in the surgery group had postoperative rebleeding and neurologic deterioration. Conclusions: among patients in whom surgery could be performed within 24 hours after an acute intracerebral hemorrhage, minimally invasive hematoma evacuation resulted in better functional outcomes at 180 days than those with guideline-based medical management. The effect of surgery appeared to be attributable to intervention for lobar hemorrhages. Next, we will be discussing articles from Journal of American Medical Association. Acetaminophen used during pregnancy and children's risk of autism, ADHD, and intellectual disability. Importance: several studies suggest that acetaminophen, paracetamol, used during pregnancy may increase risk of neurodevelopmental disorders in children. If true, this would have substantial implications for management of pain and fever during pregnancy. Objective: to examine the associations of acetaminophen use during pregnancy with children's risk of autism, attention deficit/hyperactivity disorder, ADHD, and intellectual disability. Design, setting, and participants: this nationwide cohort study with sibling control analysis included a population-based sample of 4,797 children born in 1995 to 2019 in Sweden, with follow-up through December 31, 2021. Exposure: use of acetaminophen during pregnancy prospectively recorded from antenatal and prescription records. Main outcomes and measures: autism, ADHD, and intellectual disability based on International Classification of Diseases, 9th Revision and International Classification of Diseases, 10th Revision codes in health registers. Results: in total, 185,909 children, 7.49%, were exposed to acetaminophen during pregnancy. Crude absolute risks at 10 years of age for those not exposed versus those exposed to acetaminophen were 1.33% versus 1.53% for autism, 2.46% versus 2.87% for ADHD, and 0.70% versus 0.82% for intellectual disability. In models without sibling control, ever use versus no use of acetaminophen during pregnancy was associated with marginally increased risk of autism. Hazard ratio, HR, 1.05, 95% C, 1.02 to 1.08, risk difference, RD, at 10 years of age, 0.09%, 95% C, minus 0.01% to 0.20%, ADHD, HR, 1.07, 95% C, 1.05 to 1.10, RD, 0.21%, 95% C, 0.08% to 0.34%, and intellectual disability, HR, 1.05, 95% C, 1.00 to 1.10, RD, 0.04%, 95% C, minus 0.04% to 0.12%. To address unobserved confounding, matched full sibling pairs were also analyzed. Sibling control analyses found no evidence that acetaminophen use during pregnancy was associated with autism, HR, 0.98, 95% C, 0.93 to 1.04, RD, 0.02%, 95% C, minus 0.14% to 0.18%, ADHD, HR, 0.98, 95% C, 0.94 to 1.02, RD, minus 0.02%, 95% C, minus 0.21% to 0.15%, or intellectual disability, HR, 1.01, 95% C, 0.92 to 1.10, RD, 0%, 95% C, minus 0.10% to 0.13%. Similarly, there was no evidence of a dose-response pattern in sibling control analyses. For example, for autism, compared with no use of acetaminophen, persons with low, less than 25th percentile, medium, 25th 75th percentile, and high, greater than 75th percentile, mean daily acetaminophen use had HRs of 0.85, 0.96, and 0.88, respectively. Conclusions and relevance: acetaminophen use during pregnancy was not associated with children's risk of autism, ADHD, or intellectual disability in sibling control analysis. This suggests that associations observed in other models may have been attributable to familial confounding. Single ascending and multiple dose trial of Zerlasiran, a short interfering RNA targeting lipoprotein A, randomized clinical trial. Importance: lipoprotein A is a causal risk factor for atherosclerotic cardiovascular disease, ASCADE, and calcific aortic stenosis, with no pharmacological treatments approved by regulatory authorities. Objectives: to assess the safety and tolerability of Zerlasiran, a short interfering RNA targeting hepatic synthesis of apolipoprotein A, and effects on serum concentrations of lipoprotein A. Design, setting, and participants: single and multiple dose study in healthy participants and patients with stable ASCADE, respectively, with lipoprotein A serum concentrations greater than 150 mol/L, conducted at 7 research sites in the US, the Netherlands, UK, and Australia between November 18, 2020, and February 8, 2023, with last follow-up on August 23, 2023. Interventions: participants were randomized to receive 1. A single subcutaneous dose of placebo, N equals 8, Zerlasiran 300 mg, N equals 6, or 600 mg, N equals 6, or 2 doses of placebo, N equals 9, Zerlasiran 200 mg, N equals 9, at a 4-week interval, or 300 mg, N equals 9, or 450 mg, N equals 9, at an 8-week interval. Main outcomes measures: the primary outcome was safety and tolerability. Secondary outcomes included serum levels of Zerlasiran and effects on lipoprotein A serum concentrations. Results: among 37 patients in the multiple dose group, mean age, 56, SD, 10.4, years, 15, 42%, women, 36 completed the trial. Among 14 participants with extended follow-up after single doses, 13 completed the trial. There were no serious adverse events. Median baseline lipoprotein A concentrations in the multiple dose group were 288, IQR, 199 to 352, mol/L. Median changes in lipoprotein A concentration at 365 days after single doses were 14%, IQR, 13% to 15%, for the placebo group, minus 30%, IQR, minus 51% to minus 18%, for the 300 mg of Zerlasiran group, and minus 29%, IQR, minus 39% to minus 7%, for the 600 mg dose group. After 2 doses, maximal median changes in lipoprotein A concentration were 19, IQR, minus 17 to 28, mol/L for the placebo group, minus 258, IQR, minus 289 to minus 188, mol/L for the 200 mg of Zerlasiran group, minus 310, IQR, minus 368 to minus 274, mol/L for the 300 mg dose group, and minus 242, IQR, minus 343 to minus 182, mol/L for the 450 mg dose group, with maximal median percent change of 7%, IQR, minus 4% to 21%, -97%, IQR, -98% to -95%, -98%, IQR, -99% to -97%, and -99%, IQR, -99% to -98%, respectively, attenuating to 0.3%, IQR, -2% to 21%, -60%, IQR, -71% to -40%, -90%, IQR, -91% to -74%, and -89%, IQR, -91% to -76%, 201 days after administration. Conclusion: Zerlasiran was well tolerated and reduced lipoprotein concentrations with infrequent administration. Next, we will be discussing articles from Nature Medicine. Feasibility of functional precision medicine for guiding treatment of relapsed or refractory pediatric cancers. Children with rare, relapsed or refractory cancers often face limited treatment options, and few predictive biomarkers are available that can enable personalized treatment recommendations. The implementation of functional precision medicine, FPM, which combines genomic profiling with drug sensitivity testing, DST, of patient-derived tumor cells, has potential to identify treatment options when standard of care is exhausted. The goal of this prospective observational study was to generate FPM data for pediatric patients with relapsed or refractory cancer. The primary objective was to determine the feasibility of returning FPM-based treatment recommendations in real time to the FPM Tumor Board, FPM-TV, within a clinically actionable timeframe, less than 4 weeks. The secondary objective was to assess clinical outcomes from patients enrolled in the study. 25 patients with relapsed or refractory solid and hematological cancers were enrolled, 21 patients underwent DST, and 20 also completed genomic profiling. Median turnaround times for DST and genomics were within 10 days and 27 days, respectively. Treatment recommendations were made for 19 patients, 76%, of whom 14 received therapeutic interventions. 6 patients received subsequent FPM-guided treatments. Among these patients, 5, 83%, experienced a greater than 1.3-fold improvement in progression-free survival associated with their FPM-guided therapy relative to their previous therapy, and demonstrated a significant increase in progression-free survival and objective response rate compared to those of 8 non-guided patients. The findings from our proof-of-principle study illustrate the potential for FPM to positively impact clinical care for pediatric and adolescent patients with relapsed or refractory cancers and warrant further validation in large prospective studies. Next, we will be discussing articles from British Medical Journal. Impact of large-scale, multicomponent intervention to reduce proton pump inhibitor overuse in integrated healthcare system, difference in difference study. Objective: to determine how a large-scale, multicomponent, pharmacy-based intervention to reduce proton pump inhibitor, PPI, overuse affected prescribing patterns, healthcare utilization, and clinical outcomes. Design: difference in difference study. Setting: U.S. Veterans Affairs healthcare system, in which one regional network implemented the overuse intervention and all 17 others served as controls. Participants: all individuals receiving primary care from 2009 to 2019. Intervention: limits on PPI refills for patients without a documented indication for long-term use, voiding of PPI prescriptions not recently filled, facilitated electronic prescribing of H2 receptor antagonists, and education for patients and clinicians. Main outcome measures: the primary outcome was the percentage of patients who filled a PPI prescription per 6 months. Secondary outcomes included percentage of days PPI gastroprotection was prescribed in patients at high risk for upper gastrointestinal bleeding, percentage of patients who filled either a PPI or H2 receptor antagonist prescription, hospital admission for acid peptic disease in older adults appropriate for PPI gastroprotection, primary care visits for an upper gastrointestinal diagnosis, upper endoscopies, and PPI-associated clinical conditions. Results: the number of patients analyzed per interval ranged from 192,607 to 250,349 in intervention sites and from 3,775,953 to 4,368 in control sites, with 26% of patients receiving PPIs before the intervention. The intervention was associated with an absolute reduction of 7.3%, 95% confidence interval -7.6% to -7.0%, in patients who filled PPI prescriptions, an absolute reduction of 11.3%, -12.0% to -10.5%, in PPI use among patients appropriate for gastroprotection, and an absolute reduction of 5.72%, -6.08% to -5.36%, in patients who filled a PPI or H2 receptor antagonist prescription. No increases were seen in primary care visits for upper gastrointestinal diagnoses, upper endoscopies, or hospital admissions for acid peptic disease in older patients appropriate for gastroprotection. No clinically significant changes were seen in any PPI-associated clinical conditions. Conclusions: the multicomponent intervention was associated with reduced PPI use overall but also in patients appropriate for gastroprotection, with minimal evidence of either clinical benefits or harms. Efficacy of a single low dose of esketamine after childbirth for mothers with symptoms of prenatal depression, randomized clinical trial. Objective: to determine whether a single low dose of esketamine administered after childbirth reduces postpartum depression in mothers with prenatal depression. Design: randomized, double-blind, placebo-controlled trial with 2 parallel arms. Setting: 5 tertiary care hospitals in China, June 19, 2020 to August 3, 2022. Participants: 364 mothers aged greater than or equal to 18 years who had at least mild prenatal depression as indicated by Edinburgh Postnatal Depression Scale scores of greater than or equal to 10, range 0 to 30, with higher scores indicating worse depression, and who were admitted to hospital for delivery. Interventions: participants were randomly assigned 1:1 to receive either 0.2 mg/kg esketamine or placebo infused intravenously over 40 minutes after childbirth once the umbilical cord had been clamped. Main outcome measures: the primary outcome was prevalence of a major depressive episode at 42 days postpartum, diagnosed using the Mini International Neuropsychiatric Interview. Secondary outcomes included the Edinburgh Postnatal Depression Scale score at 7 and 42 days postpartum and the 17-item Hamilton Depression Rating Scale score at 42 days postpartum, range 0 to 52, with higher scores indicating worse depression. Adverse events were monitored until 24 hours after childbirth. Results: a total of 364 mothers, mean age 31.8, standard deviation 4.1 years, were enrolled and randomized. At 42 days postpartum, a major depressive episode was observed in 6.7%, 12,180, of participants in the esketamine group compared with 25.4%, 46,181, in the placebo group. Relative risk 0.26, 95% confidence interval, c. 0.14 to 0.48, p less than 0.001. Edinburgh Postnatal Depression Scale scores were lower in the esketamine group at 7 days, median difference -3, 95% c-4 to -2, p less than 0.001, and 42 days, -3, -4 to -2, p less than 0.001. Hamilton Depression Rating Scale scores at 42 days postpartum were also lower in the esketamine group, -4, -6 to -3, p less than 0.001. The overall incidence of neuropsychiatric adverse events was higher in the esketamine group, 45.1%, 80-182, b 22.0%, 40-182, p less than 0.001. However, symptoms lasted less than a day and none required drug treatment. Conclusions: for mothers with prenatal depression, a single low dose of esketamine after childbirth decreases major depressive episodes at 42 days postpartum by about 3/4. Neuropsychiatric symptoms were more frequent but transient, and did not require drug intervention. Next we will be discussing articles from Lancet. Pembrolizumab or placebo with chemoradiotherapy followed by pembrolizumab or placebo for newly diagnosed, high-risk, locally advanced cervical cancer, ENGIT CX11/GOG 3047/Keynote A18, a randomized, double-blind, Phase 3 clinical trial. Background: Pembrolizumab has shown efficacy in persistent, recurrent, or metastatic cervical cancer. The effect of chemoradiotherapy might be enhanced by immunotherapy. In this Phase 3 trial, we assess the efficacy and safety of adding pembrolizumab to chemoradiotherapy in locally advanced cervical cancer. Methods. In this randomized, double-blind, placebo-controlled, Phase 3 ENGET-CX11/GOG3047/Keynote-A18 clinical trial, adults, age greater than or equal to 18 years, at 176 medical centers in 30 countries with newly diagnosed, high-risk, locally advanced cervical cancer were randomly assigned, 1-to-1, using an interactive voice response system with integrated web response to receive 5 cycles of pembrolizumab, 200 mg, or placebo every 3 weeks plus chemoradiotherapy, followed by 15 cycles of pembrolizumab, 400 mg, or placebo every 6 weeks. Randomization was stratified by planned external beam radiotherapy type, intensity modulated radiotherapy or volumetric modulated ARC therapy versus non-intensity modulated radiotherapy or non-volumetric modulated ARC therapy, cervical cancer stage at screening, International Federation of Gynecology and Obstetrics 2014 stage IB2 IIB node positive versus stage 3, IVA, and planned total radiotherapy, external beam radiotherapy plus brachytherapy, dose, less than 70 Grays versus greater than or equal to 70 G equivalent dose in 2 Grays fractions. Findings. Between June 9, 2020, and December 15, 2022, 1,060 participants were randomly assigned to treatment, with 529 assigned to the pembrolizumab chemoradiotherapy group and 531 to the placebo chemoradiotherapy group. At data cutoff, Jan 9, 2023, median follow-up was 17 middle.9 months, IQR 11 middle.3 to 22 middle.3 in both treatment groups. Median progression-free survival was not reached in either group. Rates at 24 months were 68% in the pembrolizumab chemoradiotherapy group versus 57% in the placebo chemoradiotherapy group. The hazard ratio, HR, for disease progression or death was 0 middle.70, 95% C 0 middle.55 to 0 middle.89, P equals 0 middle.0020, meeting the protocol specified primary objective. Overall survival at 24 months was 87% in the pembrolizumab chemoradiotherapy group and 81% in the placebo chemoradiotherapy group, information fraction 42 middle.9%. The HR for death was 0 middle.73, 0 middle.49 to 1 middle.07. These data have not crossed the boundary of statistical significance. Grade 3 or higher adverse event rates were 75% in the pembrolizumab chemoradiotherapy group and 69% in the placebo chemoradiotherapy group. Interpretation. Pembrolizumab plus chemoradiotherapy significantly improved progression-free survival in patients with newly diagnosed, high-risk, locally advanced cervical cancer. Next we will be discussing articles from Journal of Clinical Oncology. Genomic classification and an individualized prognosis in multiple myeloma. Purpose. Outcomes for patients with newly diagnosed multiple myeloma, NDMM, are heterogeneous, with overall survival, OS, ranging from months to over 10 years. Methods. To decipher and predict the molecular and clinical heterogeneity of NDMM, we assembled a series of 1,933 patients with available clinical, genomic, and therapeutic data. Results. Leveraging a comprehensive catalog of genomic drivers, we identified 12 groups, expanding on previous gene expression-based molecular classifications. To build a model predicting individualized risk in NDMM, IRMA, we integrated clinical, genomic, and treatment variables. To correct for time-dependent variables, including high-dose melphalan followed by autologous stem cell transplantation, HDM-ASCT, and maintenance therapy, a multi-state model was designed. The IRMA model accuracy was significantly higher than all comparator prognostic models, with a C-index for OS of 0.726, compared with International Staging System, ISS, 0.61, Revised ISS, 0.572, and R2 ISS, 0.625. Integral to model accuracy was 20 genomic features, including 1q21 gain/amp, del1p, TP53 loss, NSD2 translocations, APOBEC mutational signatures, and copy number signatures, reflecting the complex structural variant chromathripsis. IRMA accuracy and superiority compared with other prognostic models were validated on 256 patients enrolled in the GMMG HD6 clinicaltrials.gov identifier, NCT 024959222, clinical trial. Individualized patient risks were significantly affected across the 12 genomic groups by different treatment strategies, treatment variants, which was used to identify patients for whom HDM-ASCT is particularly effective versus patients for whom the impact is limited. Conclusion: integrating clinical, demographic, genomic, and therapeutic data, to our knowledge, we have developed the first individualized risk prediction model enabling personally tailored therapeutic decisions for patients with NDMM. Next, we will be discussing articles from Journal of Hepatology. Long-term use of tenofovir disoproxil fumarate increases fracture risk in elderly patients with chronic hepatitis B. Background and aims. The use of tenofovir disoproxil fumarate, TDF, is associated with a reduction in bone mineral density and an increase in bone metabolism biomarkers. However, data on clinical bone fractures remain limited. We evaluated the impact of TDF compared to entecavir on the risk of fracture in elderly patients with chronic hepatitis B, CHB. Methods. Patients with CHB aged greater than or equal to 60 years receiving entecavir or TDF between January 2008 and December 2022 were identified using a territory-wide database in Hong Kong. The risk of incident fracture in entecavir and TDF-treated patients before and after month 24 were compared after propensity score matching. Results. A total of 41,531 patients with CHB, mean age 69.8 plus or minus 7.8 years, 61.6% male, receiving entecavir, N equals 39,897, 96.1%, and TDF, N equals 1,634, 3.9%, were analyzed. At a median follow-up of 25.3, 9.1 to 58.5 months, 1,733, 4.2%, patients developed incident fracture. Patients with incident fracture were more likely to have diabetes, hypertension, congestive heart failure, rheumatoid arthritis, osteoporosis, and a history of fracture. Compared with propensity score-matched entecavir-treated patients, the risk of incident fracture in TDF-treated patients was comparable in the first 24 months. Weighted subdistribution hazard ratio, SHR, 0.99, 95% C 0.56 to 1.73, P equals 0.960, but increased after month 24. Weighted SHR 1.80, 95% C 1.11 to 2.93. P equals 0.019. The 24, 60, and 96-month cumulative incidences, 95% C, of fracture in TDF-treated and entecavir-treated patients were 2.3%, 1.6% to 3.4%, versus 2.6%, 1.9% to 3.5%, 6.4%, 5.0% to 8.2%, versus 4.7%, 3.8% to 6.0%, and 10.2%, 8.3% to 12.6%, versus 6.8%, 5.4% to 8.5%, respectively. Conclusions. The risk of fracture increased with TDF treatment for greater than or equal to 24 months in elderly patients with CHB. Selection of nucleoside analogs should be individualized based on age and comorbidities. Impact and implications. Previous literature suggested that the use of tenofovir disoproxil fumarate (TDF) is associated with a decrease in bone mineral density. However, data on the impact of TDF on long-term incident clinical fracture remains scarce. In this real-world territory-wide study of 41,531 treated patients with chronic hepatitis B in Hong Kong, patients who received TDF were at a higher risk of fracture after 2 years of treatment than those who received entecavir. Given the aging population of patients with chronic hepatitis B and the rising prevalence of comorbidities, our findings support the current treatment guidelines that recommend selecting antiviral treatment based on age and comorbidities. Episodic overt hepatic encephalopathy after transjugular intrahepatic portosystemic shunt does not increase mortality in patients with cirrhosis. Background and names. Overt hepatic encephalopathy, OHE, is a major complication of transjugular intrahepatic portosystemic shunt, TIPS, placement, given its high incidence and possibility of refractoriness to medical treatment. Nevertheless, the impact of post-TIPS-O on mortality has not been investigated in a large population. Results. During a median follow-up of 30 months, IQR 1230, 293 patients developed at least one episode of O. 27, 9.2%, of them experienced recurrent/persistent O. Patients with O were older, 64, 57 to 71 versus 59, 50 to 67 years, p less than 0.001, had lower albumin, 3.1, 2.8 to 3.5 versus 3.25, 2.9 to 3.6, G/DL, p equals 0.023, and had a higher prevalence of pre-TIPS-O, 15.4% versus 9.0%, p equals 0.023. Child-Pugh and MELD scores were similar. The 30-month difference in mortality between patients with and without post-TIPS-O was 0.03, 95% C-0.042 to 0.102. Multivariable analysis showed that age, subdistribution hazard ratio 1.04, 95% C 1.02 to 1.05, p less than 0.001, and MELD score, subdistribution hazard ratio 1.09, 95% C 1.05 to 1.13, p less than 0.001, but not post-TIPS-O, were associated with a higher mortality rate. Similar results were obtained when patients undergoing TIPS for variceal rebleeding prophylaxis, N equals 356, or refractory ascites, N equals 258, were analyzed separately. The proportion of patients with persistent O after TIPS was significantly higher in the group of patients who died. The robustness of these results was increased following propensity score matching. Conclusion. Episodic O after TIPS is not associated with mortality in patients undergoing TIPS, regardless of the indication. Impact and implications. Overt hepatic encephalopathy, OHE, is a common complication in patients with advanced liver disease, and it is particularly frequent following transjugular intrahepatic portosystemic shunt, TIPS, placement. In patients with cirrhosis outside the setting of TIPS, the development of O negatively impacts survival, regardless of the severity of cirrhosis or the presence of acute on chronic liver failure. In this multicenter, non-inferiority, observational study we demonstrated that post-TIPS-O does not increase the risk of mortality in patients undergoing TIPS, irrespective of the indication. This finding alleviates concerns regarding the weight of this complication after TIPS. Intensive research to improve patient selection and risk stratification remains crucial to enhance the quality of life of patients and caregivers, and to avoid undermining the positive effects of TIPS on survival. Next, we will be discussing articles from Clinical Gastroenterology. Significance of cryptatypia in Barrett's esophagus, a clinical, molecular, and outcomes study. Background and names. The aim of this study was to characterize baseline morphologic features of crypts in nondysplastic Barrett's esophagus and correlate them with DNA content abnormalities and risk of progression to high-grade dysplasia, HGD, or esophageal adenocarcinoma, EAC. Methods. The morphologic features of nondysplastic crypts in baseline biopsy specimens from 212B patients, 2,956 biopsy specimens, were graded histologically using a 4-point scale, cryptatypia levels, 0 to 3. DNA content abnormalities were detected using flow cytometry. Results. In patients who had dysplasia in their baseline biopsy specimens, dysplasia was associated significantly with increasing grades of cryptatypia in the background nondysplastic Barrett's esophagus, p less than 0.001. In a subset of patients without dysplasia at baseline, N equals 149, a higher grade of cryptatypia was associated with longer Barrett's esophagus segment length, 5.5 versus 3.3 centimeters, p equals 0.0095, and a higher percentage of cells with 4N DNA content, 3.67 plus or minus 1.27 versus 2.93 plus or minus 1.22, p equals 0.018. Cryptatypia was associated with the development of any neoplasia, low-grade dysplasia and HGD/EEC. Although no significant association was noted between the grade of cryptatypia and increased 4N, aneuploidy, or progression to HGD/EEC, only patients with grade 2 or 3 cryptatypia showed increased 4N, aneuploidy, or progression to HGD/EEC. Conclusions. Patients with Barrett's esophagus likely develop dysplasia via a progressive increase in the level of cryptatypia before the onset of dysplasia, and these changes may reflect some alteration of DNA content. Liver stiffness measurement and risk prediction of hepatocellular carcinoma after HCV eradication in veterans with cirrhosis. Background and aims. Patients with cirrhosis secondary to chronic hepatitis C virus, HCV, are at risk for hepatocellular carcinoma, HCC, despite a sustained virological response, SVR. We examined whether post-SVR liver stiffness measurement, LSM, could be used to stratify HCC risk. Methods. This was a retrospective cohort study of 1850 participants identified from the Veterans Health Administration, with HCV cirrhosis and SVR, followed up over 5,099 person-years, from the time of post-SVR elastography until death, HCC, or the end of the study. Results. The risk of HCC increased by 3% with every 1 kilopascal increase in LSM, adjusted hazard ratio, R, 1.03, 95% confidence interval, C, 1.01 to 1.04, P less than 0.001, and decreased with the number of years from SVR, R, 0.79, 95% C, 0.70 to 0.90, T equals 0.0003. The adjusted annual risk of HCC was 2.03% among participants with post-SVR LSM less than 10 kilopascals, 2.48% in LSM 10 to 14.9 kilopascals, R, 1.71, 95% C, 1.01 to 2.88, P equals 0.046, 3.22% for LSM 15 to 19.9 kilopascals, R, 1.59, 95% C, 0.78 to 3.20, P equals 0.20, 5.07% among LSM 20 to 24.9 kilopascals, R, 2.55, 95% C, 1.30 to 5.01, P equals 0.01 and 5.44% in LSM greater than or equal to 25 kPa R, 3.03, 95% C, 1.74 to 5.26, P less than 0.0001. The adjusted annual risk of HCC was less than 0.4% in participants with LSM less than 5 kilopascals and without diabetes mellitus. Conclusions. LSM predicts rates of HCC in patients with HCV cirrhosis after SVR at multiple cutoff levels and offers a single test to predict portal hypertension-related complications and HCC. Patients with LSM less than 5 kilopascals in the absence of diabetes mellitus had a low risk of HCC in which surveillance could be discontinued. Dynamics of the gut microbiome in patients with ulcerative colitis. Background and aims. Intestinal fungi have been implicated in the pathogenesis of ulcerative colitis, UC. However, it remains unclear if fungal composition is altered during active versus quiescent disease. Methods. We analyzed clinical and metagenomic data from the study of a prospective adult research cohort with inflammatory bowel disease, SPARC-IBD, available via the IBD Plexus program of the Crohn's and Colitis Foundation. We evaluated the fungal composition of fecal samples from 421 patients with UC during clinical activity and remission. Within a longitudinal subcohort, N equals 52, we assess for dynamic taxonomic changes across alterations in clinical activity over time. We examined if fungal amplicon sequence variants and fungal bacterial relationships were altered during activity versus remission. Finally, we classified activity in UC using a supervised machine learning random forest model trained on fungal abundance data. Results. During clinical activity, the relative abundance of genus Candida was increased 3.5-fold, p adjective less than 1 times 10 to 4, compared with during remission. Patients with longitudinal reductions in clinical activity demonstrated parallel reductions in Candida relative abundance, p less than 0.05. Candida relative abundance correlated with Parabacteroides diastonis, Faecalibacterium prausnitz, and Bacteroides doré relative abundance, p less than 0.05, during remission. However, these correlations were disrupted during activity. Fungal abundance data successfully classified patients with active or quiescent UC, area under the curve 0.80, with Candida relative abundance critical to the success of the model. Conclusions. Clinical activity in UC is associated with an increased relative abundance of Candida, cross-sectionally and dynamically over time. The role of fecal Candida as a target for therapeutics in UC should be evaluated. Benefits of prokinetics, gastroparesis diet, or neuromodulators alone or in combination for symptoms of gastroparesis. Background and aims. Prokinetics have limited effectiveness for treating symptoms of gastroparesis. Thus, alternative or adjunct therapies, such as gastroparesis diets or neuromodulators, are often prescribed. Their therapeutic benefits alone or in combination remain unclear. Methods. 129 patients with symptoms of gastroparesis underwent wireless motility capsule gastric emptying time and gastric emptying scintigraphy. Based on test results, changes in therapy were recommended. Changes in gastroparesis Cardinal Symptom Index, GCSI, and individual symptom scores over 6 months were related to recommendations for prokinetics, gastroparesis diet, or neuromodulators given as solo new therapies or in dual combinations. Multivariate analyses were performed to adjust for gastric emptying and other variables. Results. In the whole group regardless of therapy, GCSI scores decreased by 0.53 points, interquartile range, -1.25 to 0.05, p less than 0.0001, over 6 months. GCSI did not decrease for prokinetics as solo new therapy, p equals 0.95. Conversely, neuromodulators as solo therapy decreased GCSI scores, p equals 0.04, and all individual symptoms except nausea/vomiting, p equals 0.86. Prokinetics combined with gastroparesis diets or neuromodulators improved GCSI scores, p less than or equal to 0.04, and most individual symptoms. Adjusting for gastric emptying time on multivariate analyses showed greater GCSI decreases for non-delayed emptying for neuromodulators as solo new therapy, p equals 0.01. Gastric emptying scintigraphy, gender, diabetes, and functional dyspepsia did not influence responses to any treatment. Conclusions. Initiating prokinetics as solo new therapy had little benefit for patients with symptoms of gastroparesis. Neuromodulators as the only new therapy decreased symptoms other than nausea and vomiting, especially with non-delayed gastric emptying. Adding gastroparesis diets or neuromodulators to prokinetics offered relief, suggesting that combination therapies may be more useful in managing these patients. Next, we will be discussing articles from Clinical Infectious Diseases. Raising awareness of antimicrobial stewardship challenges in pediatric emergency care, results from the performed study assessing consistency and appropriateness of antibiotic prescribing across Europe. Background. Optimization of antimicrobial stewardship is key to tackling antimicrobial resistance, which is exacerbated by overprescription of antibiotics in pediatric emergency departments, EDs. We described patterns of empiric antibiotic use in European EDs and characterized appropriateness and consistency of prescribing. Methods. Between August 2016 and December 2019, several children attending EDs in 9 European countries with suspected infection were recruited into the PERFORM, Personalized Risk Assessment and Febrile Illness to Optimize Real-Life Management study. Empiric systemic antibiotic use was determined in view of assigned final bacterial or viral phenotype. Antibiotics were classified according to the World Health Organization, WHO, A.I.O reclassification. Results. Of 2,130 febrile episodes, Excluding children with non-bacterial/non-viral phenotypes, 1,549, 72.7%, were assigned a bacterial and 581, 27.3%, a viral phenotype. A total of 1,318 of 1,549 episodes, 85.1%, with a bacterial and 269 of 581, 46.3%, with a viral phenotype received empiric systemic antibiotics in the first 2 days of admission. Of those, the majority, 87.8% in the bacterial and 87.0% in the viral group, received parenteral antibiotics. The top 3 antibiotics prescribed were third-generation cephalosporins, penicillins, and penicillin/beta-lactamase inhibitor combinations. Of those treated with empiric systemic antibiotics in the viral group, 216 of 269, 80.3%, received greater than or equal to 1 antibiotic in the watch category. Conclusions: differentiating bacterial from viral etiology in febrile illness on initial ED presentation remains challenging, resulting in a substantial overprescription of antibiotics. A significant proportion of patients with a viral phenotype received systemic antibiotics, predominantly classified as WHO watch. Rapid and accurate point-of-care tests in the ED differentiating between bacterial and viral etiology could significantly improve antimicrobial stewardship. Treatment for first cytomegalovirus infection post-hematopoietic cell transplant in the Aurora trial, a multi-center, double-blind, randomized, Phase 3 trial comparing maribavir with valganciclovir. Background: neutropenia may limit the use of valganciclovir treatment for cytomegalovirus, CMV, infection following hematopoietic cell transplant, HCT. A Phase 2 study indicated efficacy of maribavir with fewer treatment-limiting toxicities than valganciclovir. Methods: in this multicenter, double-blind, Phase 3 study, patients with first asymptomatic CMV infection post-HCT were stratified and randomized 1:1 to maribavir 400 mg twice daily or valganciclovir, dose-adjusted for renal clearance, for 8 weeks with 12 weeks of follow-up. The primary endpoint was confirmed CMV viremia clearance at week 8, primary hypothesis of non-inferiority margin of 7.0%. The key secondary endpoint was a composite of the primary endpoint with no findings of CMV tissue invasive disease at week 8 through week 16. Treatment emergent adverse events, TEAEs, were assessed. Results: among patients treated, 273 maribavir, 274 valganciclovir. The primary endpoint of non-inferiority of maribavir was not met. Maribavir, 69.6%, valganciclovir, 77.4%, adjusted difference, -7.7%, 95% confidence interval, C, -14.98, -0.36, lower limit of 95% C of treatment difference exceeded -7.0%. At week 16, 52.7% and 48.5% of patients treated, maribavir and valganciclovir, respectively, maintained CMV viremia clearance without tissue-invasive disease, adjusted difference, 4.4%, 95% C, -3.91, 12.76. With maribavir versus valganciclovir, fewer patients experienced neutropenia, 16.1% and 52.9%, or discontinued due to TEAEs, 27.8% and 41.2%. Discontinuations were mostly due to neutropenia, maribavir, 4.0%, valganciclovir, 17.5%. Conclusions: although non-inferiority of maribavir to valganciclovir for the primary endpoint was not achieved based on the pre-specified non-inferiority margin, maribavir demonstrated comparable CMV viremia clearance during post-treatment follow-up, with fewer discontinuations due to neutropenia. SARS-CoV-2 infection and post-acute risk of non-coronavirus disease 2019 infectious disease hospitalizations, a nationwide cohort study of Danish adults aged greater than or equal to 50 years. Background: reports suggest that the potential long-lasting health consequences of severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, infection may involve persistent dysregulation of some immune populations, but the potential clinical implications are unknown. We investigated the associated risk of hospitalization due to non-coronavirus disease 2019, COVID-19, infectious diseases following the post-acute phase of SARS-CoV-2 infection. Methods: by cross-linking data from the comprehensive Danish test and surveillance system for COVID-19 together with nationwide healthcare and demographic registers, we established a study cohort of 4,694 individuals aged greater than or equal to 50 years, from January 1, 2021 to December 10, 2022, with no evidence of SARS-CoV-2 infection prior to study entry. Using Poisson regression, we compared the outcome rates of non-COVID-19 infectious disease hospitalizations following the acute phase of a first SARS-CoV-2 infection, defined as greater than or equal to 29 days since the day of infection, in recovered individuals with rates among SARS-CoV-2 uninfected individuals. Results: among 4,694 included individuals, mean age 66.8, standard deviation 11.3. years, 930,071 acquired SARS-CoV-2 infection during follow-up totaling 4,519,913 person-years. The post-acute phase of SARS-CoV-2 infection was associated with an incidence rate ratio, IRR, of 0.90, 95% confidence interval, c. 0.88. 92 for any infectious disease hospitalization. Findings, IRR, 95% c. were similar for upper respiratory tract, 1.08, 97 to 1.20, lower respiratory tract, 0.90, 87. 93, influenza, 1.04, 94 to 1.15, gastrointestinal, 1.28, 78 to 2.09, skin, 0.98, 93 to 1.03, urinary tract, 1.01, 96 to 1.08, certain invasive bacterial, 0.96, 91 to 1.01 and other, 0.96, 92 to 1.00, infectious disease hospitalizations and in subgroups. Conclusions: our study does not support an increased susceptibility to non-COVID-19 infectious disease hospitalization following SARS-CoV-2 infection. Next, we will be discussing articles from Journal of Infectious Diseases. Effective neutralizing monoclonal antibody treatment on early trajectories of virologic and immunologic biomarkers in patients hospitalized with COVID-19. Background: neutralizing monoclonal antibodies, NMAbs, failed to show clear benefit for hospitalized patients with coronavirus disease 2019, COVID-19. Dynamics of virologic and immunologic biomarkers remain poorly understood. Methods: participants enrolled in the therapeutics for inpatients with COVID-19 trials were randomized to NMAb versus placebo. Longitudinal differences between treatment and placebo groups in levels of plasma nucleocapsid antigen, NAG, anti-nucleocapsid antibody, C-reactive protein, interleukin-6, and D-dimer at enrollment, day 1, 3, and 5 were estimated using linear mixed models. A 7-point pulmonary ordinal scale assessed at day 5 was compared using proportional odds models. Results: analysis included 2,149 participants enrolled between August 2020 and September 2021. Treatment resulted in 20% lower levels of plasma NAG compared with placebo, 95% confidence interval, 12% to 27%, p less than 0.001, and a steeper rate of decline through the first 5 days, p less than 0.001. The treatment difference did not vary between subgroups, and no difference was observed in trajectories of other biomarkers or the day 5 pulmonary ordinal scale. Conclusions: our study suggests that NMAb has an antiviral effect assessed by plasma NAG among hospitalized patients with COVID-19, with no blunting of the endogenous anti-nucleocapsid antibody response. No effect on systemic inflammation or day 5 clinical status was observed. Next, we will be discussing articles from Journal of Clinical Rheumatology. Chronic nonbacterial osteomyelitis associated with familial Mediterranean fever in children. Objective: chronic nonbacterial osteomyelitis, CNO, is a non-infectious autoinflammatory bone condition that frequently occurs alongside other inflammatory diseases, such as familial Mediterranean fever, FMF. We aim to determine the demographic, clinical, laboratory, and radiological characteristics of patients diagnosed with both FMF and CNO. Methods. We reviewed the medical records of pediatric patients with both CNO and FMF at 3 pediatric rheumatology centers in Turkey from December 2008 to 2022. Patients' demographics, laboratory features, imaging findings, and treatment were recorded. Results. 12 patients with FMF and CNO were included in the study. Half of them were girls. The mean ages at onset for FMF and CNO symptoms were 80 and 116 months, whereas the ages at diagnosis for FMF and CNO were 100 and 125 months, respectively. 10 patients, 83.3%, had M694V mutation on at least one allele of the Mediterranean fever, MAFE, gene. The most common sites of osteitis were the long bones, 58.3%, pelvis, 50%, and clavicles, 25%. 10 patients, 83%, received nonsteroidal anti-inflammatory drugs, 8, 66%, received disease-modifying antirheumatic drugs. Biological therapy was administered to 5 patients, 41%, who did not respond to these treatments, and all patients received colchicine. Conclusion. The increased frequency of FMF in patients with CNO is of interest. Because most patients with CNO and FMF carried a homozygous or combined heterozygous M694V mutation, we speculated that the M694V mutation may play a role in the development of osteitis. Further studies are needed to elucidate the link between FMF and CNO. Next, we will be discussing articles from Arthritis and Rheumatology. Characterizing the neurobiological mechanisms of action of exercise and cognitive behavioral interventions for rheumatoid arthritis fatigue, a magnetic resonance imaging brain study. Objective. Chronic fatigue is a major clinical unmet need among patients with rheumatoid arthritis, RA. Current therapies are limited to non-pharmacological interventions, such as personalized exercise programs, PEPs, and cognitive behavioral approaches, CBAs. However, most patients still continue to report severe fatigue. To inform more effective therapies, we conducted a magnetic resonance imaging, MRI, brain study of PEPs and CBAs, nested within a randomized controlled trial, RCT, to identify their neurobiological mechanisms of fatigue reduction in RA. Methods. A subgroup of patients with RA, N equals 90, participating in an RCT of PEPs and CBAs for fatigue, undertook a multimodal MRI brain scan following randomization to either usual care, UC, alone or in addition to PEPs and CBAs, and again after the intervention, 6 months. Brain regional volumetric, functional, and structural connectivity indices were curated and then computed employing a causal analysis framework. The primary outcome was fatigue improvement, Chaudhur Fatigue Scale. Results. Several structural and functional connections were identified as mediators of fatigue improvement in both PEPs and CBAs compared to UC. PEPs had a more pronounced effect on functional connectivity than CBAs. However, structural connectivity between the left isthmus cingulate cortex, LICC, and left paracentral lobule, LPCL, was shared, and the size of mediation effect ranked highly for both PEPs and CBAs. Sauverage equals -0.46, ST 0.61, Sauverage equals -0.32, ST 0.47, respectively. Conclusion. The structural connection between the LICC and LPCL appears to be a dominant mechanism for how both PEPs and CBAs reduce fatigue among patients with RA. This supports its potential as a substrate of fatigue neurobiology and a putative candidate for future targeting. Next, we will be discussing articles from Circulation PAP/CO slope and oxygen uptake at prognostic value in aortic stenosis. Background. Recent guidelines redefined exercise pulmonary hypertension as a mean pulmonary artery pressure/cardiac output, PAP/CO, slope greater than 3 mm Hg middle.L-1 middle.min-1. A peak systolic pulmonary artery pressure greater than 60 mm Hg during exercise has been associated with an increased risk of cardiovascular death, heart failure rehospitalization, and aortic valve replacement in aortic valve stenosis. The prognostic value of the MPAP/CO slope in aortic valve stenosis remains unknown. Methods. In this prospective cohort study, consecutive patients, N equals 143, age, 73 plus or minus 11 years, with an aortic valve area less than or equal to 1.5 square centimeters underwent cardiopulmonary exercise testing with echocardiography. They were subsequently evaluated for the occurrence of cardiovascular events, cardiovascular death, heart failure hospitalization, new onset atrial fibrillation, and aortic valve replacement, during a follow-up period of 1 year. Findings were externally validated, validation cohort, N equals 141. Results. 1 cardiovascular death, 32 aortic valve replacements, 9 new onset atrial fibrillation episodes, and 4 heart failure hospitalizations occurred in the derivation cohort, whereas 5 cardiovascular deaths, 32 aortic valve replacements, 1 new onset atrial fibrillation episode, and 10 heart failure hospitalizations were observed in the validation cohort. Peak aortic velocity, odds ratio or per SD, 1.48, p equals 0.036, index left atrial volume or per SD, 2.15, p equals 0.001, E/E at rest or per SD, 1.61, p equals 0.012, MPAP/CO slope or per SD, 2.01, p equals 0.002, and age, sex, and height-based predicted peak exercise oxygen uptake, or per SD, 0.59, p equals 0.007, were independently associated with cardiovascular events at 1 year, whereas peak systolic pulmonary artery pressure was not, or per SD, 1.28, p equals 0.219. Peak VO2% and MPAP/CO slope provided incremental prognostic value in addition to indexed left atrial volume and aortic valve area, p less than 0.001. These results were confirmed in the validation cohort. Conclusions. In moderate and severe aortic valve stenosis, MPAP/CO slope and % predicted peak VO2 were independent predictors of cardiovascular events, whereas peak systolic pulmonary artery pressure was not. In addition to aortic valve area and indexed left atrial volume, % predicted peak VO2 and MPAP/CO slope cumulatively improved risk stratification. Next, we will be discussing articles. American College of Cardiology. 1-month ticagrelor monotherapy after PCI in acute coronary syndromes. The ultimate DAPT trial showed that compared with standard 12-month DAPT with aspirin and ticagrelor, 1-month DAPT followed by de-escalation to ticagrelor monotherapy reduces bleeding without an increase in ischemic events at 1 year among patients undergoing PCI for ACS. Description. The goal of the trial was to compare the efficacy of intravascular ultrasound, IVUS-guided versus angiography-guided percutaneous coronary intervention, PCI, among patients undergoing acute coronary syndrome, ACS, PCI. Further, it sought to assess the safety and efficacy of ticagrelor monotherapy compared with dual antiplatelet therapy, DAPT, with aspirin and ticagrelor for 12 months following completion of 1-month DAPT for ACS PCI. Study design. Initially, patients were randomized to IVUS-guided, N equals 1,753, or angiography-guided, N equals 1,752, PCI for index ACS event. All patients received DAPT with ticagrelor and aspirin for 30 days. If they had no ischemic or bleeding events at the end of 30 days, they were randomized to continuing DAPT for 12 months total, N equals 1,700, or stopping aspirin and switching to ticagrelor plus placebo, N equals 1,700. Ticagrelor dose was 90 mg BID, aspirin dose was 100 mg daily. During follow-up, a reduction in ticagrelor from 90 mg to 60 mg BID was required in 0.8% of patients. Total randomized participants, 3,400. Median duration of follow-up, 1 year. Median patient age, 63 years. Percentage female, 26%. Inclusion criteria: greater than or equal to 18 years of age. Either 1, biomarker positive non-ST segment elevation myocardial infarction STEMI, or STEMI, or 2, biomarker negative unstable angina, DS greater than or equal to 90%, ruptured plaque or thrombotic lesion. Had been randomized in the IVUS ACS trial of IVUS guided versus angiography guided PCI, for ultimate DAPT remained event-free after PCI with contemporary drug-eluting stents, DES, for 1 month on ticagrelor, 90 mg BID, plus aspirin, 100 mg QD. Principal findings? The primary endpoint of target vessel failure, cardiac death, target vessel ME, or clinically driven target vessel revascularization, for IVUS guided versus angiography guided PCI, was 4.0% versus 7.3%, hazard ratio 0.55, 95% confidence interval 0.41 to 0.74, p equals 0.0001. Cardiac death, 0.5% versus 1.1%, p equals 0.17. Spontaneous ME, 0.6% versus 1.5%, p equals 0.0143. The primary effectiveness endpoint, Bleeding Academic Research Consortium, BARC 2, 3, or 5 bleeding for ticagrelor plus placebo versus ticagrelor plus aspirin, was 2.1% versus 4.6%, hazard ratio 0.45, 95% confidence interval 0.30 to 0.66, p less than 0.0001. BARC 3 or 5, 0.7% versus 1.7%, p equals 0.009. The primary safety endpoint, major adverse cardiovascular or cerebrovascular events, cardiac death, ME, ischemic stroke, definite stent thrombosis, clinically driven target vessel revascularization, 3.6% versus 3.7%, p less than 0.0001 for non-inferiority, p equals 0.89 for superiority. Next, we will be discussing articles from journals of the American College of Cardiology. Effectiveness of clopidogrel versus alternative P2Y12 inhibitors based on the ABCD gene score. Background: an ABCD gene, age, body mass index, chronic kidney disease, diabetes, and CYP2C19 genetic variants, score greater than or equal to 10 predicts reduced clopidogrel effectiveness, but its association with response to alternative therapy remains unclear. Objectives: the aim of this study was to evaluate the association between ABCD gene score and the effectiveness of clopidogrel versus alternative P2Y12 inhibitor, prasugrel or ticagrelor, therapy after percutaneous coronary intervention PCI. Methods: a total of 4,335 patients who underwent PCI, CYP2C19 genotyping, and P2Y12 inhibitor treatment were included. The primary outcome was major atherothrombotic events, MAE, within 1 year after PCI. Cox regression was performed to assess event risk in clopidogrel-treated, reference, versus alternatively treated patients, with stabilized inverse probability weights derived from exposure propensity scores after stratifying by ABCD gene score and further by CYP2C19 loss of function, LOF, genotype. Results: among patients with scores less than 10, N equals 3,200, MAE was not different with alternative therapy versus clopidogrel, weighted HR, 0.89, 95% C, 0.65 to 1.22, p equals 0.475. The risk for MAE also did not significantly differ by treatment among patients with scores greater than or equal to 10, N equals 1,135, weighted HR, 0.75, 95% C, 0.51 to 1.11, p equals 0.155. Among CYP2C19 LOF allele carriers, MAE risk appeared lower with alternative therapy in both the group with scores less than 10, weighted HR, 0.50, 95% C, 0.25 to 1.01, p equals 0.052, and the group with scores greater than or equal to 10, weighted HR, 0.48, 95% C, 0.29 to 0.80, p equals 0.004, while there was no difference in the group with scores less than 10 and no lawful alleles, weighted HR, 1.03, 95% C, 0.70 to 1.51, p equals 0.885. Conclusions. These data support the use of alternative therapy over clopidogrel in CYP2C19 LOF allele carriers after PCI, regardless of ABCD gene score, while clopidogrel is as effective as alternative therapy in non-LOF patients with scores less than 10. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Signs of glucagon resistance after a 2-week hypercaloric diet intervention. Context. Hyperglucagonemia is observed in individuals with obesity and contributes to the hyperglycemia of patients with type 2 diabetes. Hyperglucagonemia may develop due to steatosis-induced hepatic glucagon resistance resulting in impaired hepatic amino acid turnover and ensuing elevations of circulating glucagonotropic amino acids. Objective. We evaluated whether glucagon resistance could be induced in healthy individuals by a hypercaloric diet intervention designed to increase hepatic fat content. Methods. We recruited 20 healthy male individuals to follow a hypercaloric diet and a sedentary lifestyle for 2 weeks. Amino acid concentrations in response to infusion of glucagon were assessed during a pancreatic clamp with somatostatin and basal insulin. The reversibility of any metabolic changes was assessed 8 weeks after the intervention. Hepatic steatosis was assessed by magnetic resonance spectroscopy. Results. The intervention led to increased hepatic fat content, 382%, 206%, 705%, p less than 0.01. Glucagon infusion led to a decrease in the concentration of total amino acids on all experimental days, but the percentage change in total amino acids was reduced, minus 2.5% plus or minus 0.5% versus minus 0.2% plus or minus 0.7%, p equals 0.015, and the average slope of the decline in the total amino acid concentration was less steep, minus 2.0 plus or minus 1.2 versus minus 1.2 plus or minus 0.3 micrometer per minute, p equals 0.016, after the intervention compared to baseline. The changes were normalized at follow-up. Conclusion. Our results indicate that short-term unhealthy behavior, which increases hepatic fat content, causes a reversible resistance to the effect of glucagon on amino acid concentrations in healthy individuals, which may explain the hyperglucagonemia associated with obesity and diabetes. Lifestyle intervention with smartphone and ISCM for people at high risk of type 2 diabetes, randomized trial. Aims. Although conventional interventions for people at high risk of developing type 2 diabetes are usually conducted face-to-face, such interventions are burdensome for healthcare providers. We developed a lifestyle intervention program combining lifestyle coaching via a smartphone application augmented by intermittently scanned continuous glucose monitoring without burdening healthcare providers. Its effectiveness for glycemic control and body weight reduction in people at risk of type 2 diabetes was investigated. Materials and methods. For this 12-week randomized unblinded trial with offline recruitment, participants with a hemoglobin A1C level of 5.6% to 6.4% or a fasting blood glucose of 110 to 125 mg/dl and body mass index (BMI) greater than 23 kg/m2 but less than 40 kg/m2 were randomly assigned to the intervention group, AP, and control group, C. The primary endpoint was the difference in time and range of blood glucose between 70 and 140 mg/dl, 3.9 to 7.8 ml/L, before and after the study period between the two groups. Results. Among 168 patients, mean age, 48.1 years, mean BMI, 26.6 kg/m2, and male, 80.4%, 82 and 86 were assigned to the AP group and C group, respectively. After 12 weeks, time and range of blood glucose at 70 to 140 mg/dl significantly improved in the AP group compared with the C group, minus 2.6 minutes/day versus plus 31.5 minutes/day, p equals 0.03. Changes in time above range did not differ, whereas time below range, blood glucose less than 70 mg/dl, plus 23.5 minutes/day versus minus 8.9 minutes/day, p equals 0.02, improved in the app group. BMI, minus 0.26 versus minus 0.59, p equals 0.017, was reduced in the app group compared with the C group. Conclusion. Intervention with a smartphone app and intermittently scanned continuous glucose monitoring increased glycemic control accompanied by decreased carbohydrate intake and weight loss. Further trials are needed to confirm whether these interventions can reduce incident type 2 diabetes. Next, we will be discussing articles from Neurology. Comparative effectiveness of natalizumab, fingolimod, and injectable therapies in pediatric onset multiple sclerosis, a registry-based study. Background and objectives. Patients with pediatric onset multiple sclerosis, POMS, typically experience higher levels of inflammation with more frequent relapses, and though patients with POMS usually recover from relapses better than adults, patients with POMS reach irreversible disability at a younger age than adult-onset patients. There have been few randomized, placebo-controlled clinical trials of multiple sclerosis, MS, disease-modifying therapies, DMTs, in patients with POMS, and most available data are based on observational studies of off-label use of DMTs approved for adults. We assess the effectiveness of natalizumab compared with fingolimod using injectable platform therapies as a reference in pediatric patients in the global MS-based registry. Methods. This retrospective study included patients with POMS who initiated treatment with an injectable DMT, natalizumab, or fingolimod between January 1, 2006, and May 3, 2021. Patients were matched using inverse probability treatment weighting. The primary outcome was time to first relapse from index therapy initiation. Secondary study outcomes included annualized relapse rate, proportions of relapse-free patients at 1, 2, and 5 years, time to treatment discontinuation, and times to 24-week confirmed disability worsening and confirmed disability improvement. Results. A total of 1,218 patients with POMS were included in this analysis. Patients treated with fingolimod had a significantly lower risk of relapse than patients treated with injectable DMTs, hazard ratio, HR, 0.49, 95% confidence interval, C, 0.29 to 0.83, P equals 0.008. After adjustment for prior DMT experience in the unmatched sample, patients treated with natalizumab had a significantly lower risk of relapse than patients treated either with injectable DMTs, HR, 0.15, 95% C 0.07 to 0.31, P less than 0.001, or fingolimod, HR, 0.37, 95% C 0.14 to 1.00, P equals 0.049. The adjusted secondary study outcomes were generally consistent with the primary outcome or with previous observations. The findings in the inverse probability treatment weighting adjusted patient populations were confirmed in multiple sensitivity analyses. Discussion. Our analyses of relapse risks suggest that natalizumab is more effective than fingolimod in the control of relapses in this population with high rates of new inflammatory activity, consistent with previous studies of natalizumab and fingolimod in adult-onset patients and POMS. In addition, both fingolimod and natalizumab were more effective than first-line injectable therapy. Association of age-related neuropathologic findings at autopsy with a claims-based epilepsy diagnosis in older adults. Background and objectives. Epilepsy is one of the 3 most common neurologic diseases of older adults, but few studies have examined its underlying pathologies in older age. We examine the associations of age-related brain pathologies with epilepsy in older persons. Methods. Clinical and pathologic data came from 2 ongoing clinical pathologic cohort studies of community-dwelling older adults. Epilepsy was ascertained using Medicare fee-for-service Parts A and B claims data that were linked to data from the cohort studies. The postmortem pathologic assessment collected indices of 9 pathologies including Alzheimer's disease, hippocampal sclerosis, macroinfarcts, and cerebral amyloid angiopathy. The fixed brain hemisphere was imaged using 3T MRI scanners before the pathologic assessments in a subgroup of participants. Results: the participants, N equals 1,369, were on average 89.3, 6.6 years at death, and 67.0% were women. Epilepsy was identified in 58, 4.2% participants. Cerebral amyloid angiopathy, odds ratio, or, equals 2.21, 95% C 1.24 to 3.95, P equals 0.007, and cortical macroinfarcts, or equals 2.74, 95% C 1.42 to 5.28, P equals 0.003, were associated with a higher odds of epilepsy. Of note, hippocampal sclerosis and Alzheimer's disease pathology were not associated with epilepsy, both P's greater than 0.25, although hippocampal sclerosis was not common and thus hard to examine with the modest number of epilepsy cases here. In 673 participants with MRI data, the association of cerebral amyloid angiopathy and cortical macroinfarcts with epilepsy did not change after controlling for cortical gray matter atrophy, which was independently associated with a higher odds of epilepsy, or equals 1.06, 95% C 1.02 to 1.10, P equals 0.003. By contrast, hippocampal volume was not associated with epilepsy. Discussion: cerebrovascular pathologies and cortical atrophy were associated with epilepsy in older persons. Next, we will be discussing articles from Chest. Symptoms and impaired quality of life after COVID-19 hospitalization, effective therapeutic heparin in non-ICU patients in the Accelerating COVID-19 Therapeutic Interventions and Vaccines for Acute trial. Background: therapeutic dose heparin decreased days requiring organ support in non-critically ill patients hospitalized for COVID-19, but its impact on persistent symptoms or quality of life, QOL, is unclear. Research question: in the Accelerating COVID-19 Therapeutic Interventions and Vaccines for Acute, Active 4A, trial, was randomization of patients hospitalized for COVID-19 illness to therapeutic dose versus prophylactic heparin associated with fewer symptoms and better call at 90 days. Study design and methods. This was an open-label randomized controlled trial at 34 hospitals in the United States and Spain. A total of 727 non-critically ill patients hospitalized for COVID-19 from September 2020 to June 2021 were randomized to therapeutic dose versus prophylactic heparin. Only patients with 90-day data on symptoms and call were analyzed. We ascertained symptoms and call by the EQ5D5 leaders at 90-day follow-up and a pre-planned analysis for the Active 4A trial. Individual domains assessed by the EQ5D5 leaders included mobility, self-care, usual activities, pain/discomfort, and anxiety/depression. Univariate and multivariate analyses were performed. Results: among 571 patients, 288, 50.4%, reported at least one symptom. Among 410 patients, 148, 36.1%, reported moderate to severe impairment in one or more domains of the EQ5D5 leaders. The presence of 90-day symptoms was associated with moderate severe impairment in the EQ5D5 leaders' domains of mobility, adjusted OR, AOR, 2.37, 95% C, 1.22 to 4.59, usual activities, AOR, 3.66, 95% C, 1.75 to 7.65, pain, AOR, 2.43, 95% C, 1.43 to 4.12, and anxiety, AOR, 4.32, 95% C, 2.06 to 9.02. Compared with patients reporting no symptoms, there were no differences in symptoms or in the overall EQ5D5 leaders index score between treatment groups. Therapeutic dose heparin was associated with less moderate severe impairment in all physical functioning domains, mobility, self-care, usual activities, but was independently significant only in the self-care domain, AOR, 0.32, 95% C, 0.11 to 0.96. Interpretation: In a randomized controlled trial of hospitalized non-critically ill patients with COVID-19, therapeutic dose heparin was associated with less severe impairment in the self-care domain of EQ-5D5 liters. However, this type of impairment was uncommon, affecting 23 individuals. Use and outcomes of peripheral vasopressors in early sepsis-induced hypotension across Michigan hospitals. Background: vasopressors traditionally are administered via central access, but newer data suggest that peripheral administration may be safe and may avoid delays and complications associated with central line placement. Research question: how commonly are vasopressors initiated through peripheral 4 lines in routine practice? Is vasopressor initiation route associated with in-hospital mortality? Study design and methods. This retrospective cohort study included adults hospitalized with sepsis, November 2020 – September 2022, at 29 hospitals in the Michigan Hospital Medicine Safety Consortium, a collaborative quality initiative sponsored by Blue Cross Blue Shield of Michigan. We assessed route of early vasopressor initiation, factors and outcomes associated with peripheral initiation, and timing of central line placement. Results: 594 patients received vasopressors within 6 hours of hospital arrival and were included in this study. Peripheral vasopressor initiation was common, 594, 67.3%. Patients with peripheral versus central initiation were similar. BMI was the only patient factor associated independently with initiation route, adjusted or AOR, of peripheral initiation, per 1 kg/m2 increase, 0.98, 95% C, 0.97 to 1.00, p equals 0.015. The specific hospital showed a large impact on initiation route, median or 2.19, 95% C, 1.31 to 3.07. Compared with central initiation, peripheral initiation was faster, median, 2.5 hours versus 2.7 hours from hospital arrival, p equals 0.002, but was associated with less initial norepinephrine use, 84.3% versus 96.8%, p equals 0.001. We found no independent association between initiation route and in-hospital mortality, 32.3% versus 42.2%, AOR, 0.66, 95% C, 0.39 to 1.12. No tissue injury from peripheral vasopressors was documented. Of patients with peripheral initiation, 135 of 400 patients, 33.8%, never received a central line. Interpretation: peripheral vasopressor initiation was common across Michigan hospitals and had practical benefits, including expedited vasopressor administration and avoidance of central line placement in 1/3 of patients. However, the findings of wide practice variation that was not explained by patient case mix and lower use of first-line norepinephrine with peripheral administration suggest that additional standardization may be needed. The effect of pressure changes during mechanical insufflation-exsufflation on respiratory and airway physiology. Background: respiratory muscle weakness can impair cough function, leading to lower respiratory tract infections. These infections are an important contributor to morbidity and mortality in patients with neuromuscular disease. Mechanical insufflation-exsufflation, MIE, is used to augment cough function in these patients. Although MIA is widely used, there are few data to advise on the optimal technique. Since the introduction of MIA, the recommended pressures to be delivered have increased. There are concerns regarding the use of higher pressures and their potential to cause lung derecruitment and upper airway closure. Research question: what is the impact of high-pressure MIA, HP MIA, on lung recruitment, respiratory drive, upper airway flow, and patient comfort, compared with low-pressure MIA, LP MIA, in patients with respiratory muscle weakness? Study design and methods. Clinically stable patients using domiciliary MIA with respiratory muscle weakness secondary to Duchenne muscle dystrophy, spinal cord injury, or long-term tracheostomy ventilation received LP MIA, 30/-30 cm H2O, and HP MIA, 60/-60 cm H2O, in a random sequence. Lung recruitment, neural respiratory drive, and cough peak expiratory flow were measured throughout, and patients reported comfort and breathlessness following each intervention. Results: a total of 29 patients, 10 with Duchenne muscle dystrophy, 8 with spinal cord injury, and 11 with long-term tracheostomy ventilation, were included in this study. HPMIA augmented cough peak expiratory flow compared with LPMIA, mean cough peak expiratory flow HPMIA 228 plus or minus 81 liters per minute versus LPMIA 179 plus or minus 67 liters per minute, p equals 0.0001, without any significant change in lung recruitment, neural respiratory drive, or patient-reported breathlessness. However, in patients with more pronounced respiratory muscle weakness, HPMIA resulted in an increased rate of upper airway closure and patient discomfort that may have an impact on clinical efficacy. Interpretation: HPMIA did not lead to lung derecruitment or breathlessness compared with LPMIA. However, it was poorly tolerated in individuals with advanced respiratory muscle weakness. HPMIA generates more upper airway closure than LPMIA, which may be missed if cough peak expiratory flow is used as the sole titration target. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. SARS-CoV-2 viral replication persists in the human lung for several weeks after symptom onset. Rationale: in the upper respiratory tract, replicating, culturable, severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, is recoverable for 4 to 8 days after symptom onset, but there is a paucity of data about the frequency and duration of replicating virus in the lower respiratory tract, i.e., the human lung. Objectives: we undertook lung tissue sampling, needle biopsy, shortly after death in 42 mechanically ventilated decedents during the beta and delta waves. An independent group of 18 ambulatory patients served as a control group. Methods: lung biopsy cores from decedents underwent viral culture, histopathological analysis, electron microscopy, transcriptomic profiling, and immunohistochemistry. Measurements and main results: 38%, 16 of 42, of mechanically ventilated decedents had culturable virus in the lung for a median of 15 days, persisting for up to 4 weeks, after symptom onset. Lung viral culture positivity was not associated with comorbidities or steroid use. Delta but not beta variant lung culture positivity was associated with accelerated death and secondary bacterial infection, p less than 0.05. Nasopharyngeal culture was negative in 23.1%, 6 of 26, of decedents despite lung culture positivity. This hitherto undescribed biophenotype of lung-specific persisting viral replication was associated with an enhanced transcriptomic pulmonary pro-inflammatory response but with concurrent viral culture positivity. Conclusions: concurrent rather than sequential active viral replication continues to drive a heightened pro-inflammatory response in the human lung beyond the second week of illness, and was associated with variant-specific increased mortality and morbidity. These findings have potential implications for the design of interventional strategies and clinical management of patients with severe coronavirus disease, COVID-19. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology. Efficacy of voclosporin in proliferative lupus nephritis with high levels of proteinuria. Background: in a Phase 3 study of adults with active lupus nephritis, addition of voclosporin to mycophenolate mofetil, MMF, and low-dose glucocorticoids led to significant improvements in the proportion of participants achieving complete and partial renal response as well as sustained reduction in proteinuria. This analysis examined the efficacy and safety of voclosporin in a subgroup of a Phase 3 study with proliferative lupus nephritis and high levels of proteinuria. Methods: participants were randomized to oral voclosporin, 23.7 mg twice daily, or placebo for 12 months. All participants received MMF and low-dose glucocorticoids. This analysis includes participants with class 3 or 4, plus or minus class V, lupus nephritis and baseline urine protein creatinine ratio, UPCR, greater than or equal to 3 gg. Efficacy endpoints included complete renal response, UPCR less than or equal to half a gram/g with stable EGFR, low-dose glucocorticoids, and no rescue medication, partial renal response, greater than or equal to 50% reduction from baseline UPCR, and UPCR over time. Safety outcomes were also assessed. Results: a total of 148 participants were in the voclosporin, N equals 76, and control, N equals 72, arms. At 12 months, 34% and 11% of participants in the voclosporin and control arms, respectively, achieved a complete renal response, odds ratio, 4.43, 95% confidence interval, c. 1.78 to greater than 9.99, p equals 0.001. A partial renal response was achieved by 65% of the voclosporin arm and 51% of the control arm at 12 months, odds ratio, 1.60, 95% c. 0.8 to 3.20, p equals 0.18. More voclosporin than control-treated participants achieved UPCR less than or equal to half a gram/g, 51% versus 26%, and voclosporin-treated participants met this endpoint significantly earlier. Hazard ratio, 2.07, 95% c. 1.19 to 3.60, p equals 0.01. The incidence of adverse events was similar between the arms. Mean EAD4 values remained stable and within normal range in both arms. Conclusions: addition of voclosporin to MMF and low-dose glucocorticoids resulted in a significantly higher proportion of participants with proliferative lupus nephritis achieving complete and partial renal responses as well as earlier reductions in proteinuria, with no evidence of worsening kidney function. Monoclonal gammopathy and its association with progression to kidney failure and mortality in patients with CKD. Background: little is known about the prognostic significance of monoclonal gammopathy of undetermined and renal significance, MIS and MGRS, in patients with CKD. The objective of this study was to determine the clinical and kidney outcomes of patients with CKD with either MIS or MGRS compared with those with CKD without MIS or MGRS. Methods: we conducted a retrospective cohort study from 2013 to 2018. Patients who had both CKD diagnosis and monoclonal testing were identified. Patients were divided into MGRS, MIS, and no monoclonal gammopathy groups. Cumulative incidence functions and Cox proportional hazards regression were used to model time to event data and to evaluate the association between monoclonal gammopathy status and risk of kidney failure, with death treated as a competing risk. Results: among 1,535 patients, 59.4% had MGRS, 648, 42% had MIS, and 828, 54%, had no monoclonal gammopathy. Unadjusted analysis showed that compared with no monoclonal gammopathy patients, patients with MGRS were at higher risk of kidney failure. Hazard ratio, HR 95% confidence interval, 2.5, 1.5 to 4.2, but not patients with MIS, HR, 95% confidence interval, 1.3, 0.97 to 1.6, after taking death into account as a competing risk. However, in the multivariable analysis, after adjusting for age, sex, EAD4, proteinuria, and Charlson comorbidity index, the risk of progression to kidney failure, with death as competing risk, in the MGRS group was no longer statistically significant, HR, 0.9, 0.5 to 1.8. The same was also true for the MIS group compared with the group with no monoclonal gammopathy, HR, 1.3, 0.95 to 1.6. When evaluating the association between MIS/MGRS status and overall survival, MGRS was significantly associated with mortality in fully adjusted models compared with the group with no monoclonal gammopathy, while MIS was not. Conclusions: after adjusting for traditional risk factors, MIS/MGRS status was not associated with a greater risk of kidney failure, but MGRS was associated with a higher risk of mortality compared with patients with no monoclonal gammopathy. Next we will be discussing articles is from Kidney International Reports. Implications of implementing the 2021 CKD EPI equation without race on managing patients with kidney disease in British Columbia, Canada. Introduction. We investigated the implications of implementing race-free chronic kidney disease epidemiology collaboration (CKD EPI) 2021 equation among real-world patients with chronic kidney disease, CKD, from British Columbia, BC, Canada. Methods. This study included non-dialysis dependent patients with CKD aged greater than or equal to 19 years who were registered in the Patient Records and Outcome Management Information System (PROMIS) as of March 31, 2016, index date, with greater than or equal to 1 serum creatinine measurement within 1 year before the index date. Patients with a history of kidney transplantation before the index date were excluded. CKD EPI 2021 versus 2009 equation was the exposure variable. Difference in mean estimated glomerular filtration rate, EGFR, and number, % of patients reclassified to a different EGFR category were estimated. We use Fine and Gray subdistribution hazard model to investigate the association between change in EGFR category and progression to kidney failure, incident maintenance dialysis or kidney transplantation, within 2 years. Results. A total of 11,604 patients, median age 73 years, 52% male, were included. Compared to the 2009 equation, EGFR from 2021 equation was on average 2.7 milliliters per minute per 1.73 square meters higher. Variation was higher among males. Overall, 17% of the study sample were reclassified to a category with higher EGFR by 2021 equation, switchers. The highest proportion, 28%, of patients were reclassified from G5 to G4. The risk of progressing to kidney failure was 22% less among switchers compared to non-switchers. Adjusted subdistribution hazard ratio, HR 95% confidence interval, C, is 0.78, 0.65, 0.94. Conclusion. CKD EPI 2021 equation appeared to provide higher EGFR compared to 2009 equation. This higher EGFR values appeared to be concordant with subsequent real-world CKD progression outcomes. Higher EGFR from the 2021 equation may have substantial clinical implications in both diagnosis as well as long-term care of patients with CKD. Pregnancies in women with kidney failure on home dialysis in the United States. Introduction. Women with kidney failure have impaired fertility and are at a higher risk of maternal and fetal morbidity and mortality. Little is known about pregnancies in women receiving maintenance home dialysis in the United States. Methods. Using data from the United States Renal Data System, USARDS, a cohort of 26,387 women aged 15 to 49 years with kidney failure receiving maintenance home dialysis from 2005 to 2018 was examined. We calculated pregnancy rates and identified factors, including the modality associated with pregnancy receiving home dialysis. Results. Overall, 437 pregnancies were identified in 26,837 women on home dialysis. The unadjusted pregnancy rate was 8.6 per 1,000 person-years, PTPY. The unadjusted pregnancy rate was higher on home hemodialysis, 16.0 versus 7.5 PTPY, than on peritoneal dialysis. Women receiving home hemodialysis had a higher adjusted likelihood of pregnancy than women receiving peritoneal dialysis. Hazard ratio, HR, 2.34, 95% confidence interval, C, 1.79 to 3.05. Compared with women aged 20 to 24 years, the likelihood of pregnancy was lower in women aged 30 to 34 years, HR, 0.64, 95% C, 0.43 to 0.96, 35 to 39 years, HR, 0.53, 95% C, 0.35 to 0.79, 40 to 44 years, HR, 0.32, 95% C, 0.21 to 0.49, and 45 to 49 years, HR, 0.21, 95% C, 0.13 to 0.33. Whereas Black women had a higher likelihood of pregnancy, HR, 1.40, 95% C, 1.07 to 1.83, there was no difference in likelihood of pregnancy in Asian, Hispanic, and Native Americans as compared to whites. Body mass index, cause of kidney failure, socioeconomic status, rurality, pre-dialysis nephrology care, or dialysis vintage were not significantly associated with pregnancy on home dialysis. Conclusion. The pregnancy rate in women with kidney failure undergoing home dialysis is higher with home hemodialysis than with peritoneal dialysis. Younger age and Black race or ethnicity are associated with a higher likelihood of pregnancy among women receiving home dialysis. This information can guide clinicians in preconception counseling and making informed treatment decisions for pregnant women on home dialysis. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.